This UCSD TV program is a presentation of University of California Television for educational and non-commercial use only.
So at this point, we're gonna continue on, and I'm happy to invite Dr. Bill Perry up. Dr. Perry is a clinical professor of psychiatry at the UCSD School of Medicine. He is the associate director of the Neuropsychiatry and Behavioral Medicine Service, and is also a faculty member in the PACE program. And I would venture to say has one of the largest experiences in delivering and interpreting neuropsychological tests on physicians. He has been responsible for just about every single neuropsychiatric evaluation that has happened through PACE program physicians, and has published on the topic, and we'll talk about some of the issues that I think are near and dear to all of our hearts when it comes to aging as cognition. Bill.
Good morning. I'm truly delighted to be here. However, I feel a little disadvantaged to have to give this talk following Dr. Jesty's optimistic and uplifting talk. So I'm here to be a little bit more sobering, I'm afraid. I thought I'd start with this picture because I think this depicts an image that, as Dr. Jesty had mentioned, is one that we culturally embrace of the elder physician, wise, with tremendous experience that they can draw from, and in their success in treating patients. And this is in fact supported by some literature, as Dr. Jesty had mentioned. This is just one study by Hobus in the 80s. In this study, what they did is they looked at novice versus more senior physicians, and they found that there was a relationship between correct diagnostic interpretation and age. And more importantly, and we're going to address this in a bit more detail, the kind of information that was used by the more senior physician is information that they refer to as enabling information. And this is personal information, past diagnostic information, other things that are not necessarily thought of as critical laboratory findings, which is what the younger, more novice physician was relying on. It's important to note that their initial interpretation was correct only about 38% of the time, but with additional information they were able to achieve a more accurate diagnosis. So between Dr. Jesty's lovely presentation and the information I just gave you, why are we here even considering the question about the aging physician population? Is it just ageism? Are we all conspiring to move our more senior colleagues out? Well, unfortunately, there are some concerns. And there is a literature that spans about 20 to 30 years. Much of it is problematic, and I think Dr. Miller will go into some of this in some detail. But collectively, there are suggestions that there may be a relationship between age and practice. For example, Hartz and colleagues found that there was a relationship between operative mortality, particularly in CABG, and found this with years of experience in practice. It's been shown repeatedly, and we're going to talk and explain this to some degree, that older physicians are less likely to incorporate new treatment strategies into their practice. This is older literature, but it's a theme that reappears over the last several decades in some of the work being done in this area. Older physicians have had poor performance on recertification examinations, partly because it requires incorporation of current knowledge base. Now, there are many explanations that one can have for this sort of finding. If you're very busy in practice, it gives you less time to be bringing in new information. This is a meta-analysis. So this is a study that's done where they've looked at a number of studies and they set some parameters, and they reviewed this larger database and found that of the 62 published studies that met their criteria, that there was only one study in which showed that there was improved performance in outcomes with age. All the others showed that physician performance probably declined to some degree over time. Again, this is very difficult work to be done. There are many factors that need to be addressed, and I think Dr. Miller will bring some of these to light in his talk. So why assess neuropsychological and cognitive abilities? And this is important. Physicians are among those special groups who operate in an environment unforgiving of human error, where cognitive failure can lead to catastrophic consequences. Physicians, like some other professions like pilots, have a responsibility to the public, and those of us that work in the area of assessment of physicians have a responsibility to address these concerns with our physician colleagues. Why assess cognitive abilities? Dr. Jesty had made reference to Turnbull, the PrEP program in Canada, which was really one of the first to really address cognitive abilities in physicians, and found that there was a relationship with poor performance on neuropsychological measures and difficulty for remediation. And it was really the first study to demonstrate the important role that neuropsychological assessment has in the overall assessment of physician practice. This is data from an early study that we published in the PACE program. We looked at, in this particular study, these were all English-speaking American-born physicians who were tested. This was independent of the reason that they were referred to PACE. So they had a number of avenues that they were brought to the attention of the PACE program. It could have been for significant adverse outcomes in their practice, or they may, in some circumstances, have been in the wrong place at the wrong time and had been referred to PACE for remediation. What's striking in this is that among this 150 physicians assessed, in some cases, in all cases, at least 25% of them had shown some deficit area, at least a standard deviation below expectation. And this is an age and education matched sample. And up to 40% on an attention task had shown some difficulties. So does age affect competence? Well, Dr. Jesty alluded to the fact that even in normal aging, there are physical changes that take place, cardiovascular changes, hypertensive conditions can have impact on cognitive abilities, renal changes. There's a relationship that's emerging, a strong relationship between BMI and certain cognitive functions. Pulmonary changes, urogenital changes can even impact individuals, particularly proceduralists who need to be sustaining attention for long periods of time. We know that there's decreased visual acuity, decreased physical strength and stamina, and often decreased hearing problems. I just spoke with a surgical colleague who is in his 40s, a world expert in the Da Vinci robots, and I asked him yesterday if he had known of any literature between aging and use of robotics. And he said it's very clear that the elder surgeon has more difficulty with operating using the Da Vinci robots because you have to coordinate both your eye, hand, and foot coordination bilaterally. And it's been shown, at least in his experience, it's been evident that there is an accepted understanding that this is difficult. The aging brain, again, there are certain things in normal aging that we are aware of. Decreased reaction time, decreased fine motor skills and dexterity, difficulty learning new concepts and skills. This is not to suggest that people are impaired, but there is a decline in these abilities. Decreased comprehension of complex information, decreased analytic processing, and we're going to talk about this in a moment, and decreased attention to novel details. So we need to understand the link between cognition and performance. And Dr. Jesty had alluded to the concept of crystallized versus fluid knowledge. So crystallized knowledge involves this accumulation of things that you acquire along your lifespan, things that are habitual, things that you have practiced repeatedly, and they are resistant to problems of brain injury. So as Dr. Jesty had pointed out, if you learn to ride a bicycle at age 5, even in mild cognitive impairment and early Alzheimer's disease, you can retain that ability. This is a crystallized and long-term acquired ability and knowledge. Fluid abilities, the developmental trajectory of fluid abilities. Now, fluid abilities involves novel problem solving, spatial manipulation, mental speed, and identifying complex relations among stimulus patterns. This is all what incorporates what fluid abilities are. And unlike crystallized abilities that are retained over time, fluid abilities tend to peak in the 3rd decade of life and then kind of move along, and then around the 7th and 8th decade of life we see a more steep decline in these abilities. And they are subject to being impacted by any sort of neurological insult, brain disease, brain injury, and so on. Now, this is important because one of the themes that you'll see throughout the literature in assessing physicians, the older physician, is this notion of analytic processing. And this is a very nice paper by Eva and Barnes, and they suggest that analytic processing tends to decline with age, whereas non-analytic processing remains stable. Older physicians tend to do less well when dealing with novel, conflicting, and complex patient situations. The more individuals rely on their prior experience, the less of a tendency there will be to critically assess novel, conflicting information. Now, I can tell you from my personal experience in assessing a number of physicians who have come through the PACE program who are older that this makes a lot of sense. Because as I sit with those physicians who've had practice problems, they share with me their story that I've had one bad outcome. I've had 40 years of practice. I've been doing this procedure successfully for 40 years, and I've had one bad outcome, and I've been brought before the medical board and brought over to the PACE program. And then when we explore what that bad outcome is, it starts to emerge that what happened on that particular day was something new, something novel, something stressful, something complex. I'm thinking of a case of an individual who had 2 emergencies occur at the same time, and he had to attend to both of them, and they both had adverse outcomes simultaneously. So what we see is when one can rely on their past experience, using the skills that they have developed over their lifetime, can draw from past experience, they're actually quite successful. It's on that unique experience, on that unique day, something novel, something dramatic, something complex occurs, and it taxes the individual in a way that they may be slightly compromised. So that brings us to the role of neuropsychology in assessing the aging physician. Now, I want to talk about what neuropsychological assessment is, because in the context of the aging physician, it really has 2 very different functions. The neuropsychological or neurodiagnostic assessment is one function, and the fitness for duty evaluation is a slightly different function. When we do a neuropsychological or neurodiagnostic evaluation, we're screening for covert disease, we're diagnosing neuropsychological or neurological conditions such as a dementia or a mild cognitive impairment or significant attentional disorder. We're determining if there's a health condition, a primary health condition like a cardiovascular disorder, a pulmonary disorder, renal changes, hepatic changes that may be impacting the individual's cognitive ability. And when we do this, we address the individual and we compare them to other individuals of the same age and education. So we would make statements like, compared to other 70-year-olds, this individual is actually performing quite well, and so on. In contrast, the fitness for duty evaluation assesses the physical, cognitive, and emotional capacity to independently perform essential functions competently and in a manner that does not threaten the safety and health of patients. So, quite simply, drawing from Dr. Jesty's example of the 100-year-old marathoner, I would venture to guess that there are no other 100-year-old marathoners, maybe another. And we would say, as a way of example, that individual is performing higher than other 100-year-old individuals when it comes to running a marathon. But if we were asked to put together the best team of marathoners, my guess is that he would not make that team. That what we're comparing that individual to would be a minimal level of functioning or an acceptable level of functioning, and likely we're not going to compare them to other people of his like age, of his same age. The other thing to keep in mind is Dr. Jesty had shown us some very impressive data about self-report and self-efficacy and the notion that as one is successfully aging, they are actually feeling better about themselves. But a fitness for duty evaluation really wants to focus on functionality. We need to measure individuals against some sort of standard, not simply self-report. Just to reinforce this is taken from the Federation of State Medical Boards in evaluating quality of care, and I'll just read a little bit of this to you. It reads, identify discompetence as a failure to maintain acceptable standards in one or more areas of professional practice. Performance demands differ depending upon whether the physician engages in surgery or primary care. That's very important because when you're doing a fitness for duty evaluation, you have to first understand what is the duty that you're assessing. If you are a surgeon or a proceduralist and you have significant eye-hand coordination deficits, that will impact your ability to practice safely. If you're a psychiatrist, it may have no bearing whatsoever on your ability to practice safely. And I put this last line in because this is something that I've heard from many physicians who we assess. Specialty board exams test knowledge. They don't test performance. And performance is being assessed in the ORs, at the hospitals, in the offices, and we try to make those determinations through evaluation programs. Okay, some things to consider when doing an evaluation. And this is also, I think, can be carried over to some of the issues that one has to consider when looking at the research in the area as well. Older physicians may have a lower caseload and less opportunity for peer review. It may also be the case that older physicians may have a higher caseload because they're very experienced in a particular procedure. Younger physicians may feel uncomfortable voicing concerns about their colleagues, their older colleagues. We've all learned to be respectful of our seniors. Very often our seniors have been our mentors, so it's very difficult to raise concern about their practice. Detecting subtle cognitive impairment of older physicians is difficult because we assume, and there's some data to suggest, that the physician group has an above average starting point, intellectual functioning. So when there is a decline, the standard cutoffs may not apply. And in fact, in one study done where they took a very crude measure of cognitive abilities, the mini mental status exam, and they applied the regular normal cutoff of 26, very few of the older physicians that they assessed had shown any problems. But when they used a higher cutoff of 28, still below what we would expect from our practicing physician, that number increased fairly dramatically. Physicians in solo practice may escape scrutiny by peers. It's clear that if you're a proceduralist and in the hospital and there are more people observing you, then you're more likely to see where one's deficits lie. Hospitals may be lenient because it's difficulty replacing physicians, particularly in outlying areas, and hospitals may be reluctant because there's a large amount of revenue that's generated by a particular physician practice, and so they may be more tolerant of error. So all of this is just to highlight some of the difficulties in self-report and in acquiring data to support whether or not someone is having a practice problem. When you use neuropsychological testing, what testing do you use? It's a major question. I think there's some people here who are struggling with that issue, and I've received phone calls from people around the country, and it's unclear. And I can tell you there's basically two schools. There is the school that you can use computerized batteries. Many of the larger programs do that. Colorado, we have a computerized battery that we use, and Michigan uses several. These are heavily weighted on attention and reaction time. Some have complained that the older physician is not as facile with computers. That's true. It's one of the limitations. Other groups use a comprehensive paper and pencil battery, and I just took the battery that the PrEP group in Canada uses. It measures a number of things: attention, concentration, memory, verbal fluency, and we're going to talk about these areas very briefly. So, in general, when we assess neuropsychological functions, we look at domains. Independent of which measure you use, be it a cognitive, be it a computerized measure or one of the paper and pencil tests, there are certain domains that we typically assess in a comprehensive battery. One of them is premorbid intellectual abilities and reading skills. And what I've put to the right side are some of the things that we want to consider when we're doing a fitness for duty evaluation. Because quite frankly, if the concern is that this person has Alzheimer's disease, at least in my role, that's usually picked up earlier. It's not me that is necessarily going to make that determination, although we've had a few cases where in the course of our evaluation we determined that there was at least some significant evidence that this was an early Alzheimer's picture. But that's less likely to be the case. It's usually there's maybe a concern that's been raised, and so our job is to understand, is there something that is cognitively mediating this particular problem? So when we look at premorbid abilities, we want to look at that because we want to be able to assess, has there been any decline in their function over time, and our tests can help us determine that. Will this person be able to profit from continuing education? That's clearly important because we need to address remediation. Do they have the ability to understand and communicate in English? This has important patient-physician implications. Attention. The ability to attend and determine what is critical and salient. So we often will use measures that will tax the individual both in short-term and sustained over time. And we try to use measures that will tap into different domains, auditory and visual domain. The ability to inhibit impulsive and incorrect responses. Okay. If you start off with an incorrect decision, do you have the ability to change midstream? These are the kinds of questions we as assessors have to ask and interpret the data to help those people who have to make decisions about practice, the practice parameters for that individual. Learning and memory, the ability to learn and integrate new information as well as draw from past experience. Yes, that is memory, but we couch it in these terms because we want to know, will this person be able to integrate new information if they need to be participate in a remediation program of any sort, and integrate that information into their current practice. The ability to recognize and recall information efficiently and quickly without irrelevant information impeding. Perceptual motor skills. I mean, this is a very critical area, particularly for proceduralists. And there is some data here that has shown relationships between some of our standard neuropsychological measures and performance in surgeons in particular. Obviously, the ability to perform the physical task, eye-hand coordination. We have yet to incorporate a eye-hand-foot task, but it sounds like with robotics we may have to look towards that. The ability to manipulate instruments with accuracy. I recently involved in a case where an individual was asked to do a task where they had significant problems manipulating and in their fine motor dexterity, and they were an interventional cardiologist. And they argued that there was no relationship between that task and their practice, but unconvincingly. Executive function skills. Recognizing the significance of unexpected situations in order to quickly make alternative plans when unusual events arise. Think back to the case I shared with you a moment ago, an individual who was practicing and had, had encountered any sort of adverse events over the course of his career, and later in his career had the unfortunate circumstance of two unusual events that he could not manage simultaneously, and his alternative plans were, his alternative decision-making resulted in a mortality. Planning and decision-making abilities, and error correction and troubleshooting. That's really one to underline, error correction and troubleshooting. We all make mistakes, but does one have the ability to recognize that and change the course of action? So, to summarize about neuropsychological aspects of physician assessment, we reviewed a literature, and and Dr. Miller will really go into this in more detail, that there is, as Dr. Jesty said, there is certainly evidence that people can age successfully, and they can maintain a high level of performance and function well into their senior years. But there are cognitive changes that we are aware that most people experience, that these changes can impact physician practice. And we linked cognition to performance. Older physicians draw from prior instances and rely more heavily on non-analytic processes. Dr. Jesty was referring to that. In fact, people can draw from this wealth of experience, and they may be very successful having seen cases like the one that they're confronted with on any given day early on, that they can draw from that prior experience to help them with their decision making. The difficulties usually arise when it is something unusual, something novel, and when there are time concerns attached to it. We talked a bit about the role of neuropsychology in assessing the aging physician and explained the difference between neuropsychological assessment or neurodiagnostic assessment and a fitness for duty evaluation. The fitness for duty evaluation emphasizes practice. The neurodiagnostic assessment emphasizes truly disease and disorder and deficits. And remember that you can have an impairment, but it may not impact your ability to practice. An example, taking it outside of the realm of medicine, if I were to cut my finger badly and needed to be stitched, chances are it would have no impact on my ability to be a neuropsychologist, a psychologist. If I were quarterbacking tonight for the Chargers, I'd be on the disabled list. So the impairment itself really depends on what the function is that we're asking of the individual. So I thought I would end with this because I do want to, it's not quite as optimistic and uplifting as Dr. Jesty, but I think we come to the same place. I want to leave you on an optimistic note. remediation is possible and change is possible. And this is from a 2008 paper by Constantinu. Doctors can accommodate cognitive decline by choosing to cease procedural work, and that's if people are having difficulty doing that. And that, frankly, is the most difficult thing to convince an individual of, that maybe it's time to cut back. They can allocate more time to each patient. They can use memory aids. There are a number of things that we can do. Cognitive remediation, things to assist individuals in their daily practice. They can seek advice from trusted colleagues, and they can seek second opinions. The important step, from my perspective, is that we need to increase our research, and we can identify specific strategies for continuing education for older physicians and a way to have them continue to contribute to their colleagues and to the practice of medicine. So I'll stop there.
So are there any questions for Dr. Perry? And if you have some, please use the microphone.
Hi, my name is Bill McCauley. I'm from the College of Physicians and Surgeons of Ontario, home of the PrEP program. First, I want to congratulate both you and Dr. Jesse on your excellent presentations. They were really fascinating. I wanted to clarify something about the PrEP program based on Jeff Turnbull's publication in 2000. When we assess people's cognitive function only when they perform poorly at PrEP. So if someone is going to go on to require remediation, we want to know if their cognitive abilities are such that they're likely to be successful. So it's only once we've identified through a performance assessment that there are significant concerns do we go on to do cognitive assessment. And when we do that, we don't use a specific battery of tests. That battery of tests that were outlined in Dr. Turnbull's paper were the tests that were done specifically for that study. We do a comprehensive both pen and paper and computerized testing. And to that end, we have worked with a couple of neuropsychologists who have developed a neurocognitive battery of tests that are supposed to be specific to the domains required from a physician in their work. They have developed the test using 10 different domains. I think there are 30 different tests that are being used, and we are just about to launch a pilot of that on a random selection of quote-unquote normal physicians, where we are randomly selecting physicians to undergo this testing so we know what normal means, so that when we do go ahead and use this battery on physicians with identified competence issues, we'll be able to compare them to the norm, and we're not using any corrections for age in that battery of tests. So thank you for the talk. It'll inform our work significantly.
That's great. Thank you.
And I add my thanks to the speakers. I'm Jenny Blake from Toronto with two questions. One is very interesting to put the two talks together and to reflect back on the value of experience. And I think we all recognize the value of experience in our colleagues. But in practices that are volume-driven or fee-for-service, there actually is a large pressure to work quickly to look for similarities and not to be sensitive to the novel aspects that you've described. So in professions where the compensation reflects compensation for seniority, such as law, do you see the same pattern as you might see in medicine, which tends to be more fee-for-service or volume-based practice? And the second question is, given wearing my hat as a gynecologist, all the interest around the effects of estrogen on the female brain and impact on the fluid of brain cognitive function and memory and trail making and all those other functions, has anyone looked at gender and midlife as a factor?
Well, I don't have an answer for the first question because I don't know the literature as it extends out to the law profession. I don't know. It's a good question. I do know that, and I'm not an expert in this area, but I know that there's obviously a very extensive literature with pilots, and so they, and there's a very clear, and there are pilots. I mean, it's been part of the profession for years. I mean, there's been a forced retirement. And there are serial assessments that happen on an annual basis and sometimes even twice a year. In terms of gender differences, there's It's part of the complication of looking at this literature. It's particularly in a senior physician population, it's overwhelmingly more male than female. So we're starting off with not a very vast literature to begin with studies that have limitations that Dr. Miller will address. And then I don't know personally of any study that has, I know that there was one study about gender differences, but I don't remember anything specific about it. And it certainly didn't look at some of the underlying biological processes that are important. It's clear that this is a wide open field in need of the kinds of studies that you were suggesting. I mean, we don't even have data on normal practicing physicians. It's when you do a comprehensive assessment that might take 1 to 2 days to complete, it's very hard to gather a normal sample of folks that say, sure, I'll take a few days off and come in and volunteer to be a subject in your study. You know, I'll take a movie ticket and that'd be great as my compensation for the day. So there's some very definite difficulties in doing this kind of work, but it's very necessary to proceed in this fashion.
I think Dr. Miller is making his way to the microphone.
Great. Thank you all.
Oh, 1 second. We got one more.
Oh.
You're not getting away yet.
Bill, I have to make one comment about specialty board examinations and their meaning. Certification extends far beyond the examination. If the examination is multiple choice dealing with cognitive knowledge, you're right on. But specialty board certification is much wider in its scope and needs to be even wider than that.
Again, that's a good point. I think that's important. I do think, I'll say that I think there are certain biases. It's inherent in our field. I can tell you that even in research, you may get an article from a very senior person and think, this is not certainly something that I think should be published. It's very hard to send back a review and say, I think they're wrong, and this is not worthy of publication. It is inherent in the way we have been raised in academia to not question older, very senior individuals. And we're more forgiving at times. So I agree, this is a complex area, a complicated area, and I'm delighted that people are approaching it from a variety of perspectives and really tackling this because it's critical. Thank you.
All right, thank you, Dr. Perry.